Welcome to CATCH program. I'm Dr. Madhu Rao, Chief of Cardiology, CMC Hospital. With me on the panel, Judy Christeller. She's Associate Professor of Pharmacy in Wilkes University. And to my right is Dr. Stafford Smith. He's Interventional Cardiologist, CMC Hospital. You already heard about coronary artery stenting. And once we have these stents placed in, we need to continue to manage the patients medically. The major concern about stenting is reocclusion of these stents, and platelets do a major role in causing stent occlusion. Stafford, can you talk about the role of platelets in stent thrombosis?
Oh, certainly. Platelets are considered a bad actor when it comes to angioplasty and particularly with stent deployment. We have a concern of stent thrombosis after stent deployment, and it appears by the data that's currently available, the use of dual antiplatelet therapy, that would be the use of aspirin and thienopyridine, can reduce that incidence. Platelets are small fragments within the blood that come from larger cells, megakaryocytes. They carry a number of active agents that attract other platelets and attract other clotting factors. Platelets aggregate by connecting to each other by fibrinogen, and they use von Willebrand factor to attach to collagen, which is the area of the blood vessel that's going to become exposed after angioplasty.
It is reasonable to say that the mechanism of acute coronary syndrome is what we call a plaque rupture. When the plaque ruptures, it exposes the underlying tissue in the blood vessel to the blood, and that's where the platelets aggregate and cause a blockage. Ironically, that's exactly what we are doing in stenting. We are breaking the plaque, putting a foreign body in, and so the platelets are activated. So that's where the role of dual antiplatelet therapy comes in.
Absolutely.
Now, Judy, can you tell us about the limitation of these antiplatelet agents that we have?
Sure. Dr. Smith mentioned that we have clopidogrel, which is also known as Plavix, and a newer drug is now prasugrel, which is known as Effient. One of the problems with Plavix or clopidogrel is it can have a variable benefit in different patients. Plavix, in order to become an active drug, has to be metabolized through the liver, and certain percentage of the population is not able to completely metabolize this to its active drug. So in those patients, it's thought, now the data is not clear on this, but it's thought that they could have a diminished effect or a diminished benefit of the Plavix because they're not able to metabolize it completely to the active drug. And this can occur in up to 20 to 30% of the population. It's more common in African Americans and Chinese patients. So you can have a beneficial effect of Plavix. Another reason why you could have a beneficial effect is there's some drug interactions with Plavix, specifically potentially with proton pump inhibitors, which are drugs that we commonly use for what we call GERD or gastric reflux. Now, patients that take proton pump inhibitors, this can be Prilosec or Prevacid. There's some potential for a drug interaction with Plavix, so it could potentially cause a diminished effect. The data is very unclear on this, but it's a good idea to try to avoid this effect if you can. One way you can avoid that effect is by taking your proton pump inhibitor at least 4 to 6 hours before your Plavix to prevent that drug interaction. Whether it's clinically significant or not is really unknown. One of the benefits of prasugrel or Effient is that it doesn't undergo the same metabolic pathway, and so there's not going to be this genetic variation with prasugrel, and there's also not these drug interactions with prasugrel. But regardless of whatever drug you take, whether it's clopidogrel or prasugrel, either one, you have to make sure that you take these medications every single day. And you might have some side effects, some bruising, but you still need to take these medications. Sometimes a dentist or a surgeon might advise you to stop taking your medication, and you should not do that until you talk to your cardiologist, because that could increase your risk of having a stent occlusion or a heart attack.
I think that's a very important advice to the patients. They do not stop the medications without consulting their physicians, because if you do stop the medications, there is always a risk of stent thrombosis. Now, we have 2 drugs available in the thienopyridine groups, and So where do we go from here? What do the guidelines say? When do we use them? How long do we use them, Stafford?
Well, and excuse me, in 2007, there was a science advisory that came out when they realized the importance of using these medications, particularly in the setting of post-percutaneous coronary intervention. And they advised against early discontinuation of these two medications. And they also advised delaying any elective surgical procedures that an individual might be contemplating. This was picked up upon during 2009, an update to the guidelines that came out by the American College of Cardiology and American Heart Association. They listed as a Class 1 indication the early use of these medications as soon as possible at the time percutaneous coronary interventional procedure was determined to be performed, and its absolute continuation for at least 12 months and absolute avoidance in any early discontinuation. There was one study, the CURE trial, which is actually an older study because its results became available before the use of drug-eluting stents, which did show at least a 12-month benefit in the use of dual antiplatelet therapy together. There's actually a large randomized study that's ongoing now that probably won't be available until 2015 called the DAPT trial, which should put a lot of these issues to rest.
So in summary, we like to, if you have an acute coronary syndrome and you get a stent, you like to continue this dual therapy at least for 1 month, 1 year.
Oh, absolutely.
On an elective basis, it's totally different. Depends upon the type of stent you have. Otherwise, in all acute coronary syndrome, you like to continue them for 1 year.
And particularly in drug-eluting stents.
Drug-eluting stents, right. And the recommendation for carotid stenting is the Plavix needs to be continued only for 1 month.
Absolutely.
And after that, aspirin needs to be continued indefinitely. Now, one of the things about prasugrel that you mentioned before, you don't have to worry about the genetic testing. Correct. And you don't have to worry about drug interactions. But basically, there are some concerns about prasugrel. Can you talk about the concerns we have on prasugrel?
Well, actually, clopidogrel came with a box warning regarding the genetic problems that might be associated with its metabolism. Prasugrel also has its own box warning, and that box warning is about an increased incidence of bleeding. In the clinical trials that were done in regards to prasugrel, they did identify specific high-risk groups, particularly those that were underweight, those that were elderly, and those that had suffered a prior stroke or TIA. And the choice of this medication should probably be avoided in those particular groups of patients.
That's good. Thank you. Now, we all talk about dual antiplatelet therapy in coronary artery disease patients after the stent. There are certain situations we may have to go for what we call triple therapy. There are patients who have an arrhythmia called atrial fibrillation, and these patients need anticoagulation, and the common drug that has been used all along is what we call warfarin or Coumadin. Unfortunately, the combining 3 drugs has an increased risk of bleeding. Stafford, can you comment about the risk of triple therapy and the bleeding?
Yes, as we have an aging population, we have more patients that are requiring stenting procedures, and we have more patients that are running into atrial fibrillation. There may be a lifetime risk of atrial fibrillation that can approach 20 to 25%. Certainly that risk is increased in elderly, it's increased in specific patient subgroups that have suffered a prior stroke and those that have suffered a prior MI. But the risk of stroke in individuals that either maintain their atrial fibrillation or go in and out of atrial fibrillation can be 4 to 5 times greater than that of the general population. That's an age-adjusted risk. So if they meet criteria, there's currently a CHAD score that we use to decide who's appropriate to receive anticoagulation. If they meet the appropriate criteria to reduce their risk of stroke, they should remain on anticoagulation. So now you're running into a problem with an enlarging population that either has coronary disease and has stents and develops atrial fibrillation, or the opposite situation, those with atrial fibrillation that may run into a coronary problem and require a stent, and now you're faced with the option of suggesting triple therapy, which for all rights and purposes we think that they will require. There appears to be a risk of major bleeding with dual antiplatelet therapy. That's approximately 1% or so. That can go up to about 7% on triple therapy.
That's interesting. Now, we do have a lot of problem with taking care of patients on Coumadin therapy, Judy. We have seen the interaction with the food and the need for close monitoring. And where do we go from there? Do we have any alternative?
So there's two agents that are approved, two anticoagulants that are approved to prevent a stroke in patients with atrial fibrillation. There's the Coumadin, which is also known as warfarin, and also dabigatran, which is a newer agent, also known as Pradaxa. Both drugs can prevent a stroke in patients with atrial fibrillation. Where you might use Pradaxa is with patients on Coumadin, you have to make sure that they're in a normal therapeutic range. We measure that with their INR. That's why you have to do all the blood testing with it. In patients on Coumadin that have a consistently therapeutic, they're in the normal range of INR for stroke prevention, there's no benefit of adding Pradaxa, of switching them over to Pradaxa. It's not going to decrease their risk of stroke anymore. But in patients that are not consistently in a therapeutic range, then those are the patients that you might consider using Pradaxa, because it's been shown to decrease their risk of stroke better than Coumadin if they're not consistently in a therapeutic range. So there's some limitations of Pradaxa. One is that for both Coumadin and Pradaxa, if you bleed, you can reverse Coumadin, but we can't reverse Pradaxa. So if there's life-threatening bleeding, we can't reverse that agent.
At the same time, the half-life is short, so
the half-life is shorter, so it shouldn't have that long of an effect. Another difference is with warfarin, we have to monitor the INR, but with Pradaxa, we don't. So you can't really tell if your patients are being compliant, and there's some reasons why they might not want to take the medication. You have to take it twice a day instead of once a day with Coumadin. They might have a higher incidence of stomach upset. And then the cost is higher out of pocket for patients with Pradaxa. And so these reasons might make it so that patients are not as compliant with taking their medication. Pradaxa also has to be used cautiously in patients with kidney disease. You can adjust the dose, although there's not a lot of evidence to show that it's effective at that dose reduction. And patients with severe kidney disease, you might just avoid using it altogether.
Good. Now, do you have any guidelines for people who are taking the new drug Pradaxa if they have to go for a surgical procedure?
There are some guidelines in terms of they will need to talk with their physician. Depending on the surgical procedure, they'll need to stop taking the Pradaxa a few days before the procedure, but that depends on the patient's risk for bleeding, and it also depends on the procedure. So they will need to talk to their
and depends
physician.
on the renal functions, kidney functions too.
Yes.
Very good. Thank you. Now, what does the future hold for us, Stafford, in terms of newer antiplatelet agent or newer antithrombotic agents? What do you see in the future?
Well, Dr. Rao, there were 2 clinical trials conducted within the past year, one regarding an agent called apixaban and the other rivaroxaban, which are factor 10 inhibitors, which appear very promising and could compete with some of the other anticoagulant agents that we've discussed. The other thing is more of a technological issue. There's a new imaging modality called optical coherence tomography. This is similar to intravascular ultrasound, but it provides much more detailed, high-quality, high-resolution images from the inside of the vessel to look at stented areas. This way we can be certain that an area that's been stented is fully covered by endothelium and that there's no bare areas of metal exposed which might attract platelets. And this may, in some way, enhance our ability to allow some of the patients to come off of these medications earlier than expected, and particularly in those in a high-risk group, those at risk for bleeding.
In summary, we need to address vascular disease with risk factor modification, in addition to medical therapy, in addition to stenting. Stafford and Judy, thank you very much. That was an excellent discussion and summary of dual and triple antiplatelet therapy.